more than 39 million people worldwide suffer from blindness. In up to 80% of cases, it is treatable or preventable. Cataract is the most common cause of blindness, which can be treated quickly, effectively, and cost-efficiently. Improving access to care is a central element of transforming care delivery, one of the fundamental challenges facing healthcare providers worldwide. Innovative and effective approaches exist to tackle this challenge. Blindness is more prevalent in developing countries. In India, with its population of more than 1.3 billion people, receiving effective and affordable treatment is difficult. The model of the Aravind eye care system successfully improves access to care by addressing the three main barriers: affordability, availability, acceptability. To meet the affordability challenge, Aravind developed a business model that drastically lowers costs by increasing workforce productivity and producing consumables in-house. As a result, they can perform cataract surgery 98% cheaper than in the US.
The organization was founded by a gentleman who was about 58 when he founded it, and his primary purpose was eliminating needless blindness. And look at India in 1976, with a very poor economy, with a per capita income of about $150. And he also realized very early on that he's not going to build a model which is going to be on donations from somebody. So that's how he built. He built a cross-subsidizing model. Today's model in 2019, about 60% of the people can afford to pay for surgery. But back then in 1976, it was only 20%.
Another challenge Aravind faced was to make their services available to patients. Many of them cannot travel to a hospital due to costs, having to remain at work, and the need to be accompanied by someone. To address this, Aravind implemented a hub-and-spoke model, optimized their clinical operations, and they actively reach out to their patients.
This whole logistics of getting patients into a hospital is a very different exercise. So for us, what it means is going into the community, screening the population, and surfacing the patients. It's usually 10 to 15% of the people that we see. If we see 500 people, we will get about 60 to 75 people who have cataract. And we need to bring them. So transportation becomes our responsibility. Feeding the patients becomes our responsibility. Making them stay in the hospital for 2 to 3 days becomes our responsibility.
Acceptability is the third dimension of access to care. And while acceptance of eye surgery in Aravind's service area is generally poor, their superior outcomes and clear communication reduces their patients' fear and anxieties. Among Aravind's patients, the outcomes are as good as in the European Union, and even better than in the UK.
Aravind does about 500,000 surgeries a year, and our aspiration is to go to about 1 million surgeries in the next 3 to 5 years. And as Dr. V's words, which are the foundation of the organization should strive to do something beautiful. It's a beautiful journey to give sight to somebody, to see a smile on their face when they can wake up and look at their grandchildren. And that's the journey we are on, putting more smiles in the world.